This is Kevin with the Academy. I'd like to welcome you to today's Business Partner webinar hosted with PMMC and the Metro Health System, Net Price Transparency Requirements, a study in adapting to state legislation. As slide 2, you have the opportunity to ask questions during the webinar by typing them in the space provided in the open Q&A field on the right-hand side of the screen. We will take brief pauses to field questions on slides 15 and 26 and at the conclusion of the webinar. If you sense at any point during the webinar, please call our membership services team at 888-700-5223 for personal attention. As always, today's program is being recorded, and registered attendees will receive a copy of the presentation by email within the next couple of days. To discussing price transparency compliance efforts and how they can be affected by state-level legislation. When launching or modifying price transparency initiatives, it can be helpful to gauge how familiar patients are with key terms and with the process of accessing the information they need. With that in mind, I would like to launch today's first in-conference poll. Has organization surveyed patients on how well they understood their financial responsibilities before service? The answers are yes, no, and then to within 12 months. The question is, have organizations surveyed patients on how well they understood their financial responsibilities before service? The answers are yes, no, and to within 12 months. In the case study portion of today's webinar, let's briefly review the origins of price transparency and some of the common compliance efforts currently in the industry. The general documents guiding price transparency are the Affordable Care Act and the 2015 Inpatient Prospective Payment System Final Rule. ACA requires that hospitals publicize a list of their standard charges for items and services. The 2015 IPPS Final Rule offered a bit more guidance. Hospitals have significant leeway to determine how to publicize that information. The possibilities include posting the charge master online or advertising how patients can access the information. Many state legislatures also have enacted state-specific price transparency requirements. The extent of those laws and the effects they have had on patient education differ widely. A 2016 Catalyst for Payment Reform report card on price transparency laws, which was released by the Healthcare Incentives Improvement Institute, only states lack any type of price transparency legislation. You can figure on this slide, though, that while many of states do have legislation, the Institute considers only a few of them to be high quality and/or effective. Many revenue cycle leaders have long been juggling local and national price transparency requirements as you try to maintain overall compliance. And so, like our speaker today, are grappling now with preparing for newly passed laws that remain unclear in some respects, which is complicating compliance efforts. Throughout this, we have seen hospitals try compliance routes, each of which has pros and cons. For example, because the 2015 IPPS Final Rule specifically mentions posting the full charge master online, this appears to be the most direct route to compliance. As found, though, this results in an unwieldy patient resource that is hard to navigate and that can leave users with incomplete information and unanswered questions. Another option is to post median gross charges online, which is a rolling average of actual costs and might be a bit more exact than charge master prices. But because factors affect patients' costs as gross charges are converted into actual out-of-pocket responsibilities, this still result in patients having incomplete information. A third is to select the highest volume of outpatient services and patient DRGs, and to offer charges online for only those options. This can result in a narrower list that is easier for users to navigate. Because common services and DRGs would be included, it's likely that many patients would find what they're looking for, though not all. And because patients will be looking for services or DRGs that are not in the selected group, price transparency would still be limited. Many hospitals have started offering a hotline that patients can call or a form online that they can use to request a price estimate. This approach is beneficial because it's easy for patients and they'll receive a response tailored to their insurance benefits or thereof and their expected service. However, patients must wait for staff to contact them to share the estimate once it is ready. And if patients didn't submit complete or accurate information when they requested the estimate, the process can be delayed. Responding to the growing trend of patient self-service, in which patients are expressing a desire for the ability to perform many revenue cycle tasks on their own, such as scheduling an appointment or setting up a payment plan, Some hospitals offer an online estimator tool. These tools to quickly and easily receive an estimate without staff intervention. The accuracy of this approach can be affected if patients do not understand their insurance benefits or do not have correct information to plug into a calculator. The easiest option for patients might be to proactively mail them estimates without waiting for a request. It's easy to see, though, why that would be burdensome for revenue cycle staff and potentially an inefficient use of limited resources. Pros and cons of all these strategies. Some providers have decided to implement more than one approach to price transparency. For example, at Metro Health, many insured patients can use an online self-service tool to generate their own estimates, but patients also can request a detailed, staff-prepared price estimate too, in addition to other price transparency initiatives. Metro also is currently dealing with a price transparency law scheduled to go into effect at the beginning of 2017, which means they are working to adapt as we speak. With that, I'd like to pass things over to today's speaker, Donna Graham, the Senior Director of Revenue Cycle Operations at Metro Health. Donna, take it away.
Those who are, and the support that HBI and PMMC teams are allowing me to share a Metro Health story about our journey through pricing transparency and also the impact of the 2015 IPP final rule and the impact of Ohio Bill 52 starting in January of 2017. Metro Health is considered an essential hospital. It's in Cuyahoga County, and we have one main hospital and over 26 sites in all of the community. They primarily are also considered hospital HOPD. We have a couple of medical offices. We do over 1.2 million visits a year, and as you can see, we have almost 600 physicians. I've been in the healthcare business for over 21 years and have had the opportunity to see the changes in healthcare going back and forth from fee to value-based pricing, and this is a very good opportunity because of the fact that we really are now talking about being very patient-centric and concentrating on quality driving reimbursement rather than contractual management driving reimbursement. If we could go to slide 8, please. Thank you. Today I'm going to talk about primarily what our journey has been with Ohio, and based on best of federal pricing transparency requirements, our situation has been very, very similar, where we opted to take on multiple methods because of our patient population. And everyone has different preferences in how they want to get information, whether it's through talking with someone, independently trying to get information, and receiving information in writing. So we follow all of those types of situations. On slide 9, as to Ohio pricing transparency grades, I'm going to say that Metro really would pass. It's really been since 2006 that Ohio has been requested to share pricing, and we basically have done that on our web. We also are required by the Ohio Department of Health to provide our top 60 inpatient diagnoses, which are severity adjusted for DG, also our top 60 outpatient services based on volume. Metro Health has used the Hospital Association as a partner to submit information to ODH. The bad part is ODH has decided not to aggregately take this information and for comparisons as they did beyond 2010. I think one of those reasons may have been because the Ohio hospitals are required to post the same services on their website, so they determine that patients can get that information in other ways, in addition to other hospitals being able to look at pricing. On 10, we basically move into what has occurred since 2014 with the Accountable Care Act, which basically have caused major increases in deductibles for patients. Although more people can be served through healthcare exchange, it's more difficult now for patients to actually afford their health care because the price sharing is much more expensive on their part based on premiums that they select. And as you can see here, Ohio is ranked in the top 5. Actually, I'm pleased to say they were literally only second to Texas a couple years ago. So we are managing deductibles a little bit better. When this started to occur, Metro decided to actually provide a survey to community in Cuyahoga County and other areas of Ohio, including our own patients. And what we really found is that as much as patients want to be informed, they really don't understand it enough to do the research. And this is showing you that out of a population of about 100 people responding, which was about 10% of the survey sent out, which is not unusual, 34% never researched it. Basically, almost 70% were going into their services without understanding what that cost would be to them and what really their insurance cost would be. Only 90% actually were proactive in looking and seeking out estimates. And finding that since this survey, even more are seeking estimates, so that's a good thing. The more informed, the better the expectation is for the hospital and then also for the patient. On slide 11, I just wanted to talk a little bit about Metro's pricing transparency and the history. As I mentioned, since 2006 at least, we've been publishing our rates. And basically, we've added in 2013 payer links that our patients could actually go to our own website, and based on the insurance, they could tap a link, and that would take them right to their insurance portal so that their own insurance company could provide them with an estimate. We threw our own website because we felt that it's very difficult to navigate through many of the payer portals, and we could provide guidance to the patient when in their own portal as to how to access it. They're actually looking for possibly defined different type of insurance jargon, et cetera, that we may be accustomed to, but the patients are not. We also discussing our own estimates, not only to patients, but also to consumer advocacy groups like ARP and also senior citizen groups. And we started to get quite a bit of shoppers in 2013. Although we are an essential hospital and we're in Cuyahoga County, we actually get international shoppers who may be moving to Ohio, and they're actually looking to deliver their children here. So they're looking for what are the gynecology, what are the OB and the delivery pricing, in addition to some other things that Metro's very much known for. In addition, another venue that we use are letters to our Medicare patients so that they can see, on average, what our visit charges would be to see the provider, and also certain procedures that seem to be those that are most frequented by our Medicare patients. And this provides them information before their visit so they can reach out to us with any questions. It also allows us the opportunity to talk to the Medicare patient to ensure that they may have enrolled in Medicare Part B or they've chosen some other secondary insurance. Oftentimes, Medicare patients don't realize that they need to enroll, nor that there's a cost associated with it. So we can facilitate with financial coordination. And of course, as Beth mentioned, the traditional patients may call us, our pre-service center, and we give estimates by phone. And then we always confirm with a letter to our patients. And we have very many ways in which a patient or the consumer can contact us regarding patient estimates. Slide 12, in order to be able to accomplish this, we feel it's very important to provide certifications and education for our staff so that the community understands that we do have experts in the field to facilitate, provide estimates, provide financial coordination, and able to reach out to our community and patients so that we can be knowledgeable and feel confident in the information that we give them. Basically, when ACA started in 2014, we have a total of 38 staff that are actually certified application counselors. In addition to those staff prior to that, we're all certified hospital access associates, and all our managers have the NAHAM certification for hospital access also. This allows our staff professionals to feel confident about the information that they're providing, and our patients and community to feel confident about their information they're getting to remove any financial barriers. we moved out in the community with slide 13, more proactive, and move away from we're just providing our patients information about pricing transparency and estimates. And we were very fortunate that we had a 38-foot RV at the hospital that was being used for other programs, but it wasn't being used on a regular basis. So probably about 3 months out of the year, it would be on the road for clinical services. So what we did is we actually collaborated with the other programs, and we turned it into an enrollment vehicle on wheels. So instead of concentrating just on our sites where we had financial coordination and ways to get patients assistance with either enrolling in insurance or financial programs, we really staffed the RV, and we staff it probably about 95% of the year in the wintertime, as long as weather permits, so that could educate patients on preventative care, continuity of care, and how they should not be concerned about not having coverage, because that's what we're experts to do, to navigate them through care exchange, Medicare, Medicaid, and other financial programs that they may be eligible for, including financial assistance. So basically, since March of 2014, when we launched the RV, we've literally assisted 4,000 people, and we're able to enroll 70% of those individuals in insurance programs. New patients to us who we didn't have before the RV, we probably run at about a 10% enrollment of brand new patients. This helped us provide preventative care and have a healthier community, but it also helped us with reducing expenses because patients' acuity levels were lower going through care, and it reduced the emergency visits we were seeing. So we're taking care of the community as well as managing our expenses appropriately. We made sure that everybody understood, because you know you always have statistics, that really all of these numbers are about people and making a difference. And we saw that in our programs, we really were able to manage population health because we were managing diabetes and other care that was needed, and helping people truly understand by applying their lifestyles, by seeing a physician earlier, by having medical management right there for them. It's not just about navigating their financial care, but also navigating their clinical care. On 14, as well as we thought we were doing, then we got involved, of course, with the 2015 IPP system and also Bill 52 that we needed to look at. And so we did a checklist, basically, of everything that we did. And we had a very robust checklist, including reaching out to the community. But where we felt that we could even do better is being able to make the patient innocent. All of our patient focus groups, what people were frustrated about is they appreciated the financial communication. They appreciated us proactively reaching out to them, but they really wanted to be able to be independent and start to learn on their own. And just like with all of the various websites, do research on their own. And that's when we made a decision that it wasn't just about us proactive in reaching out to patients or answering phone calls. It was let them in the convenience of their own home to be able to start understanding pricing transparency and what their out-of-pocket costs would be and how their insurance or what their bills potentially could be if they came to Metro. So this one, we really started to talk about leveraging technology. And it started as simple as it would be. It started to feel like it was becoming a little more complicated. And so we reached out to individuals and advocacy groups. And if you go to slide 15, we talk about how we can have this independence and engage our consumer to be more knowledgeable. We put out an RFP. We were looking for a partner that would be able to provide us with a pool site where patients could do independent research in reference to their costs. PMMC was awarded the RFP because of flexibility in regards to being able to not only within our staff's requirements for estimates, but also develop with us this online patient estimator portal that we're going to discuss. It wasn't something that just came out of the box. It was truly collaboration with many of our teams so that we could discuss with communications, we could discuss with our IT team, we could discuss with our physicians, our patient advocacy groups, our patient focus groups, what does the patient truly, truly want to see? So the way in which that we were managing the unknowns was reaching out and getting everybody else's questions answered, and PMMC partner with us to tailor something specific to patient estimates. Are there questions at this point?
Thank you. At this time, we'd like to pause and share the results from our first in-conference poll. As a reminder, that question was, your organization surveyed patients on how well they understood their financial responsibilities before service. 90% of attendees said yes, 40% of attendees said no, and 33% said they plan to do so within 12 months. Next poll asks, does your organization offer a self-service patient cost estimator online? The answers here are yes, no, and plan to within 12 months. At this time, we'd like to open the first question and answer session with Donna and with two PMMC representatives who we have on the line today, Terry McManus, Vice President of Product, and Steve Martin, Regional VP of Sales. If you have a question, please type it in on the right-hand navigation pane in the Q&A field. This will place your question in our queue. Our question is, how do you conduct your patient survey about their research on financial costs?
In our survey, we literally have a monthly meeting with a patient focus group. They have a very diverse group from those who are uninsured, underinsured, insured, working all elements of the city. And we basically asked multiple questions of them, and you saw a snippet of the survey that not only we mailed out, but also of what the patient focus groups reviewed. And everything came with, it's too complicated, we need to keep it simple, we need to understand it. And then in a group of 20 people, I would say you'd always have 2 to 3 that had a different opinion what all that meant, which that's people, it's all about perception. We also participated in AdPow pilot, which was a national pilot, and we were one of the actual individuals who promoted positive pay statements, positive billing, et cetera. And so through that, they also had surveys similar to ours, asking about what people wanted to see. And repeatedly, it was they wanted to not be surprised, but didn't want to always have to talk to people. Part it was because they didn't know what questions to ask, and a part of it, they just didn't have time to be on the line and to talk with people. So send all the questions about how much do you know about your insurance, how much do you know about what the insurance allows, what you pay, what the language of insurance is, and where do you go to get further information. They knew that they could call or even send emails. That wasn't enough for them because oftentimes people were embarrassed about asking the questions. So based on probably was about 25 questions, and I showed you the top 4 responses, that's what led us towards the independence for the patient and community engagement, and also for the patient autonomy. They wanted to provide them with something that they could go on their own, research, and that if they wanted to reach out to us, we would be there for them to help.
Great. Our next question is from Noelle, and asks, you say you had 38 staff members certified as application counselors. How many are in the counseling group in total?
Basic percent. So we have a combination of descriptions, but in those 2 different descriptions, they all are responsible for financial coordination. And so, like I said before, they were already certified, and then what we did is we required that all of them take their CAC, and that's an annual update. With the healthcare exchange, very similar questions are asked, as our financial coordinators are asked. So we felt that it was a very good marriage to make sure that everybody had that. And it promoted our own employees, as I mentioned before, to feel confident in the information they were sharing.
Thank you. Question is from Pamela, and she asks, do you have a central group that is responsible for price estimates?
The group responsible for price estimates are my pre-service group. They have been providing estimates, as I mentioned, since 2006 in various venues. And so they understand insurance, they understand billing, they understand CP coding and procedure coding, and they definitely have the patient-centric sensitivity to understand talking about financial commitments that are needed for elective services, and also understanding how to reach out to our financial coordination team in reference to facilitating assistance when a patient may need to make payment arrangements or may have the capability of enrolling in Medicaid or Medicaid after Medicare or any of the financial programs that we have. So even though it's a different team, they're very collaborative, making sure that for the patient it's one-stop shopping.
Great. And then our question for this session, and then we'll move on with our presentation. Do you use your RV only during ACA open enrollment, or do you use it year-round?
The RV is actually used year-round, and as I mentioned, we're out on the road probably 95% of the time. We have a calendar that's posted on our website, and we also partner with community venues such as the food truck, different type of health fairs, different type of organizations that assist the homeless or assist those who are in addiction recovery, et cetera. And so as large as the RV is, we really can go almost anywhere. Church groups bring us, et cetera, and we go anywhere within Cuyahoga County. And that's truly, truly reaching out to the community, because it is incredible amount of people who just do not seek health care unless it's an emergency, because they don't understand that Metro Health is accessible to us. And we have a phenomenal team that goes out on the RV, and we actually have people coming to the RV from the community asking for that team's name specifically so that they can get enrolled. And again, that's an extension of all of our buildings where we also provide that same kind of service. We're moving into financial coordination, hopefully first quarter of next year, where for the few sites that we might have people at because of the volume being so low, we actually be able to have the telecommunication there so somebody can see the coordinator face-to-face. And then we also have 24/7 inpatient and emergency department coordination. And we're very fortunate in that we have the Medicaid expansion, Medicaid redetermination program. And so for us in the last several years, we have a big opportunity to get more individuals in Medicaid, do HCE and other plans.
Thank you so much, Donna, and attendees for inputting your questions. At this point, move forward in our presentation.
Beth. Basically, on slide 16, we're going to talk about the offering of self-service estimates, and we're going to discuss some of the thought processes and philosophies. And as I mentioned before, we really wanted to be able to commit to patient or community independence, engagement, and autonomy where the patient or community wanted autonomy. Going to nuts and bolts of the self-service estimator could be very easy. You just put your pay your top, serve it out there, and fly. It was really not that easy. With the financial literacy about a bill being very complex, it makes it more complex in the self-service world. We've had key asks for a patient. It typically is ask them information that they very simply know, their demographics, or insurance name, or what their copay is. They didn't really know all the jargon clinically even when an appointment is made. They knew they needed it, the doctor said they needed it, and therefore they scheduled the appointment. Then, as I mentioned, we put out an RFP. We were looking for a partner that understood estimates, that understood insurance allowables. PMMC being a national company and being so well versed in it, we used them in the past for other type of contract modeling, pay estimate, insurance estimate, information. And they are just phenomenal in not only being able to be flexible and agile, but being able to take all of that information from claims, from contracts, et cetera, being able to bring that information into something meaningful that contract management can understand, our own departments and revenue cycle can understand, and also equate that to what a patient can understand in regards to estimates. And so when we were reviewing and doing the selection, we only looked at that expertise, but we were also looking at somebody who would partner with us to be able to come up with a patient portal that appeared to be simple and was transparent, that people would not have to understand the complexities behind it. And that is why PMMC was awarded that contract, because of the proven history they had with us and ability not only to leverage technology, but to tailor it specific to our needs and our population. We also worked with our communication group, our department group, and also our IT. So when we were approaching our patient advocacy groups, we could bring with them and choices so that they all had a thumbprint on what we were developing together. We needed to have an easy feel and touch. We needed to know how much information to put on the website, but also be concise enough so that the patients and community would get the answers that they were looking for, and not so much information that they would be discouraged. I, for one, can't do something on a website that I can get in a couple of minutes or less. I typically get discouraged and I pick up a phone call, which was not the purpose of this patient self-serve web portal. Our pre-service teams are very skilled in what we've done before, so they had firsthand knowledge also of all the questions they got asked regarding estimates and where we needed to integrate with financial coordination, et cetera. So we knew it wasn't just about providing an estimate, but we also had to have the web portal engaging enough so that we would be able to provide outreach and financial education to the consumer, and ensure that even the uninsured and underinsured could use this website and reach out to people to help them with understanding what the cost would be specific to them. So that's a pretty big group of individuals that we needed to reach out to. So the remaining slides we're going to go through, starting with 17, is going to talk a little bit about the technical aspects and then also about what our thought process was when we were going through the technical aspects. Could you change to slide 18? Thank you. So basically gave you kind of a generality of what we were doing. Some of the stuff is really doing your data mining. What are your top diagnoses and procedures that are being asked about? Not necessarily what your top diagnoses and procedures are in reference to what the hospital and your providers are doing. And it was a very interesting discussion because we used PMMC also for our charge master and for contract modeling, and quickly we found that for the CM and for contract modeling, what was considered the top for them certainly was not the top for the patient estimates. We had those discussions, which was one of the lessons learned, to be honest with you, because I think people were thinking that they would bring in the same information as it went to payers and diagnoses, and it's not. So it brought some very healthy discussions between both teams, and the result was really, through PMMC and us, is that we really need to keep it in sync, but where do we start with our priorities? So, of course, we started our priority about what the patients want to see. I mentioned that we needed to be simple. I mentioned that we needed to have common language before. We wanted to make sure that we were always confirming an estimate. So although in our estimator we provide information, we made sure that we were disclosing that it was an estimate and that we would confirm something in writing if they were more interested in it. You could see that we added 14 care contracts, and we also added 34 procedures within 12 specialties to started with. So on slide 18, as we continue with this, basically, I'm from Missouri. I like to see happening, and the bottom line is this is a landing page, and this just came out with the button at the bottom which says My Cost Estimator highlighted in yellow. We launched this in July. Our web folks were not ready. They had an emergency product. And so My Cost Estimator ended up being on the landing page, but it was buried in a listing of all kind of activity and functions that our patients could access on financial assistance program. And we knew we wanted it on the landing page because there's three things that patients always ask about. How do I pay my bill? How financial assistance, which could be assistance with getting insurance or the HCE program, and what is it going to cost me? So you'll see later, I'll explain why it's so important on the landing page to have that estimator right there forefront when a patient opens up your website. And then on page 19, I know you're going to hear me say this a lot, the disclaimer is essential. And we have a disclaimer prior. We use something very similar for the web estimator. We have our legal department review the disclaimer. We did not want to discourage people from using the estimate because, as you know, when you're getting pre-cert from insurance, they always have a disclaimer, well, we're giving you an authorization number, but we're not guaranteeing payment. We didn't want patients to have that kind of an attitude, but we did want them to understand, and you can see it in the middle, final determination, really critical. So we wanted our patients to understand we'll do this information, but you should not stop here. So it's extremely critical, and we did, and it's extremely critical with the verbiage, which our patient focus group agreed with it also. And then slide 20, we nitty-gritty, and this is really where I'm going to basically say PMMC flourished, and Greg and Terry are on the Steve is on the phone and Terry's on the phone, and Greg, who's not on the phone, also was very helpful, and the entire team of people managing this project with us. Based community and on the literacy of people that relate to understanding insurance, et cetera. Well, and I'm a school teacher also, or was a school teacher, people learn differently. People learn by reading, people learn audio through conversation, and people learn through visual. And it was very important to us to have visuals. It was very important to be able to filter so that the patients wouldn't have to filter through things that would not even be applicable to them. Again, we didn't want to discourage the patient. So quickly, this was put in. Initially, we said, well, let's just put in a figure. And, of course, I said, well, let's do a figure of a male and a female. So the PMC team was very, very patient, very collaborative, and they brainstormed with us. So the fact that we put a male and female, and you could select a part of the body, automatically that started to filter the information in the service category so that we would not have services when you sort a male or male services when you sort on the female. So that was the automatic filtering that we were able to get very, very quickly. Now, for the example, we provided colonoscopy, but you can see below all the services categories that we were actually listing. The service was used because the word specialty was very confusing to people. And also, there could be services that primary care provides, like vaccines. So in the world of healthcare, that's not considered a, quote, specialty. It's considered primary care. So that's kind of the thought process we were going through in reference to even the visual and just the service category. On page 21, we have some additional discussions about which services provide. And again, we took claims and we ran them by CPT code DRG from top to bottom of utilization by each payer, actually, and because that can also differ, of course. And then we have some payers that bring in more volume than others. It was very specific not only to the category of CPT codes of DRG, but also to the category of our payers. And so this basically gives you the services that we looked at. And I can tell you, if you go down a little bit, we're asking for copay and coinsurance, which again took many, many meetings of conversation. Where you see my professional services, in Ohio we have many labor groups, for instance, what we call split coverage. Their professional coverage is different than their technical coverage. Now, our hospital, my department actually is responsible for both professional billing and hospital billing. So for us, our estimate has to represent both sides of the fence. For others, that may not be true. So the first thing was to be able to provide guidance. If they did have split coverage, they'd be able to put what their copays were in coinsurance for professional and technical. The second question that says they either know their deductible and out-of-pocket, that's important because some patients may know their deductible right that minute. We're only going to know their deductible based on whether or not we get it, but another claim could come in and 2 minutes later that could change. So we give patients the option to give us as much information as possible. We actually did have on here a selector for max benefits. When we looked at our patient population with our payers, max benefits was not something that was really common, and we thought it may cause more questions than not, even if we had a hovered help over it where those question marks represent we're asking for the patient. So we took max benefits right off of it. Again, we didn't want people to say, I don't know that, and leave our website. So the next one on page 22 is being able to actually get the estimate. I already did that, but anyways, the service benefits I just actually explained. And just wanted to point out here, even we ask this, if the patient is uninsured, then what happens is when they copay, they actually have a pop-up that tells them what the next step is. You can see the uninsured patients. And this is actually showing us also all the insurances that we have loaded today. And we have a list of about 25 more that we're going to be loading within the next 3 to 4 weeks. So then finally could go to the next page because press get my estimate and get a full estimate. Now this is a very simple estimate, but you can see that under copay amount, we actually show the total, but we show what the hospital is and what the professional is. Same thing with coinsurance amount, if the hospital and the professional, and if the patient gives a deductible, and what the responsibility of the patient is. And again, we're providing that this is the best estimate to reach the patient in case they forgot. They have the capability to print the estimate, and this is what they would see printed, and so have the ability to reach out to our patient, to our pre-service center. What we are not showing here is the screen for our uninsured patients, but there actually is a screen that tells our uninsured patients what they can actually look at and talk to us. And go to page 24, you're going to see what they actually receive. The reason we do this is because we do not want patients to become concerned if seeing an out-of-pocket expense that they cannot afford, and encourage them to contact us. Now, we have a very rich financial assistance program for uninsured, and so if they are uninsured and they're already on that program, they're aware of it. We're using Metro Health Financial Assistance Program. If they've never been through that program, then we give them another number so that we can work with them and make a determination if there's, again, HCE, Medicaid, other governmental programs, or one of our financial assistance programs that can get them involved. And we don't charge anyone full charge algorithm based on where uninsured and underinsured are seen, if it's trauma unit or burn unit, if it's through our Life Flight program, and or based on their actual level of income. And if a person truly is 100% self-pay and they don't qualify for what people would traditionally think is a financial assistance program, we still do provide a discount so that full charges are not billed to our patients. So typically, we service everybody, and the estimator is to engage the patient and be able to talk to them. One of the things I wanted to mention on the screen also is we had a lot of conversation. Do we require patients, even with insurance, to give us our demographics, et cetera? We do not. That was a philosophical decision. That part of our philosophy was to give people autonomy, allow them to shop. Eventually, we may set up comparison shopping right on our website. So we did not want to require people filling out demographics or filling out email address or a phone. We give them that as an option if they choose to do it once they print their estimate, but as a requirement, because that would go against the philosophy of opening up this web portal to everyone, regardless as to whether they want to contact us or not. We can manage how many times it's opened, et cetera, but we do rely on the patient to let us know if they want to contact us. So if you go to slide 25, we set up and now it's to maintain. And so, as I mentioned, we just launched in July. So we are going to be additional payers and services. However, we needed somebody to control this and to manage it and to collaborate with PMMC. There's a lot of things that we can do on our own, like add additional services, additional categories, additional procedures. We also collaborate with PMMC in reference to the actual payers because they are literally loading our contracts for us. So not only are we updating our CDM with them on a regular basis, we're able to get our contract loads if there's any changes or any new contracts. So we have a combination of our estimates based on claim history and also based on our specific contracts. So we engaged Julie Narek, who is our pre-service manager, who works under Phyllis Cleary, who is our director of patient access and enrollment, and she really works with her team in reference to responses from patients, et cetera, and what we're seeing on the web portal, and also our other estimates that we provide, and to keep updating this portal. Our web group, our communications group, and our IT group are really impressed by how easy it is to collaborate with PMMC when we need their involvement and quick turnaround, as well as how quickly they update, or even Julie herself do the updates, without having an IT background in the areas that we need those updates to take place. So then we go to page 25. Continuous patient education. Just because this is out there doesn't mean that patients are going to use it and then just leave. They're going to call us. We are very proud that our estimates are extremely close, and I'll explain that again in a little bit later. But when we're talking to the patient and we're giving estimates, make sure that it's more robust than the dollars. And what I mean by that is a mammogram could have one out-of-pocket expense. However, breast density and tomosynthesis and other services that may be provided, we do let the patient know that there is the potential that there could be other charges. And oftentimes the patient then will share with us that they do have a situation where they believe they need bone density, breast density, and from there we are able to give them other information. A second example is that cost of delivery. We always want to have a healthy baby. There's challenges sometimes where the baby may not be healthy. So when they're asking for information in reference to deliveries, basically what happens is we will also have the discussion that this is referring to a healthy baby. And if there's any challenge challenges that they may already be aware of, we able to give them some estimates as it relates to that, and we actually do that. I'm going to let you know that for some reason my system did crash. Can I be heard?
Yeah, you just fine.
All right, so I'm going to go Plan B and since I can't see the website, and I'm going to go to the paper copy. Basically, those are examples so that we can expound upon estimates. Not that the estimate itself may not be close, but rather that there could be other circumstances that we would need to discuss. Another example would be potentially an implant. If it's just a shopper, we could give them a full estimate, but when they reach out to us, we like to tell them once they have a discussion with their doctor to please let's reconfirm the estimate in case for some reason there was a decision that the implant that was chosen, let's say somebody 68 years old, was an implant for knee replacement for somebody less active, but this person was a professional tennis player and needed a knee implant that would last longer and take more endurance. So those are the kinds of discussions that we have once we engage with the patient. This one is page 27.
I think we'll pause here to have another question and answer session. We'll also share the results from our previous in-conference poll. And as a reminder, that question was, does the organization offer a self-service patient cost estimator online? 18% of attendees said yes, 6% said no, and another 18 said they plan to do so within 12 months. The poll for the day asks, will your organization be changing price transparency efforts within the next 12 months in response to state legislation? The answers are yes, and uncertain. Our audience question comes from Pamela, and she would like to know, do you collect on those estimates while providing them over the phone?
Yes, we do. In fact, that's extremely important because that also gives the opportunity when we talk to the patient to collect in full. It opens up communication as to whether or not that patient has the capability of collecting in full. And if we believe that there is the propensity to pay but not the capacity to pay, then that's when we move into a deposit, possible payment arrangements. If we find that even with that, there may be a Medicare patient who doesn't have any secondary insurance, that moves us into financial coordination. So we collect as much as we can, and often we do collect all of it right away, but also provide an expectation for both us and the patient if it cannot be collected immediately.
Our next question comes from Pamela, who asks, what registration or billing system are you using?
Use Epic.
Kim asks, not patients are tech savvy, so who handles the patients that are not able to do the self-service? And do they then get a letter, a verbal estimate, or both?
It is a pre-service department. As I said, we've been doing estimates for 10 years. And so patients or even the community, if they go to our website, there's always been a listing of to contact our service area, or if they ask a provider, or if they ask our operators, or any of the departments, everybody knows to reach out with a phone number and give it to the patient. So that can be done by telephone with no problems. And then what we always do is follow up with a confirmation letter with patient. We have a lot of Spanish-speaking individuals, so we can ask the patient what they have a preference, and we will have someone on the phone with them in reference to the estimates, and then send out a letter estimate in Spanish if we need to. And then also, because we also have individuals who speak languages, we ask their preference, and we have a translator line for immediate assistance with that. Also.
Great. Next question comes from Anne, and it might be one more for the PMMC folks on the line. She wants to know how easily this setup could be modified for another hospital or health system.
Yes, good afternoon. This is Tara McManus with PMMC. It's actually very easy to set up for anybody who currently has our Estimator Pro product. The The framework for generating self portal is already built within the system.
Thank you. Our last question for this session, and then we'll move on, comes from Kim, and she asks, do you roll all charges up under a main CPT, such as supplies, pharmacy, and hourly charges, or do you list them separate on the estimate?
What we basically do, and we have this even for our statements, is on the hospital side, we have created user-friendly revenue codes, if you will. So we have roll-ups in that sense. If somebody is interested in more itemization, we can provide that because of the fact of using claim history in addition to contract. So we will have those separated. We also would have anesthesiologists separated so that the patients clearly can define what are the providers and what type of providers from implants and supplies and that type of thing.
This time we'll move on in our presentation.
Okay, thank you. I'm still on paper, so we're going to move to page 28. And basically, this is letting you know where we're going from here. Lessons learned, and I think I mentioned to you what we thought would be extremely simple. It is from a technical perspective, but it's more complicated, comprehensive, might be a better word, from a philosophical process. So what we put in, I mentioned philosophically what we were looking for, anonymity and engagement and independence. And what we found, as soon as we put this in, we weren't getting immediate hits, but I mentioned to you, we had it under financial assistance. It just helped validate that we really needed that button on that web page, which we always wanted. And it really was a motivator for our web team to be able to get it expedited on the web page, even with their other projects that were going on. So we basically, since we went live, we were able to have a 9% increase of utilization, which I'm going to say had a big impact basically on that button, putting it on the landing page. So visual is extremely important. Also, we are about 0.5 to 1% around our estimates, which is excellent because we have knowledgeable individuals in combination with the claim history and the contract management that PMMC has provided us in doing this estimate. We're really proud that we stay very close to what inform patients. Now, 1% can be a big difference depending on how big the bill is. But I mentioned to you before, we give patients information that could cause that bill to be more. So there still is no surprises. And I mentioned the implants. Bariatric surgery is another one that never quite know what's going to take place once the person has a surgery. So we try to bullet items that could be exceptions. Page 29, or 29, we really want to make sure that we consider all the possible costs, and as the question was before about supplies and implants and how we roll things up, we really don't leave much on the table, if anything, because we have the historical claims that we can look at and what the average is out of those claims. And typically for similar procedures, if there's no major comorbidity or complexity healthcare-wise, the average really winds up coming up very much the same. And if there are outliers, that tells us that that's where we need to inform the patient more about what type of outliers they expect and possibly what those outliers may cause them. And develop logical limitations when launching programs. We really had this nirvana thought because we use this validation software built into Epic that we would build it in PMMC, and we were very excited about that. And then when we actually looked at what that meant, if patients would have to answer all those questions, they would get through the first page. So we decided that we could be extremely concise and not bulk the patient down with a lot of questions that they may not even be able to answer. So it was a great idea. Everybody would say yay to it, even the patient focus group, until we showed them what that actually take. And even to try to default all that information back, they'd still have to be able to address it. And for now, we've put it on the table. Slide B for future. We're going to add more payers and more procedures. But what we're going to do is extend the use to our sites that promote same-day and non-emergent services. We have 7 centers that we consider our express cares. They're not urgent cares, where you can walk in without an appointment. This is an excellent opportunity to give an estimate right there, real time, while the patient's there, and it takes no more than a minute or so. We're bringing our portal to be in Spanish and also the estimates that come out of there. We had a question that was, well, are we just going to print the estimates in Spanish? And, you know, you asked that question, I think we all kind of grinned and said, well, how that good? They have to read it in the first place. So, again, an obvious question, may not have an obvious answer, but we're going to have the website itself. And then also, we're working on getting the estimator linked to our self-service appointment scheduling and check-in that we have on the web. And a fourth that isn't here, but we are looking at it, is how we can integrate chat into the self-patient estimator so the patients, if they have any further questions, could just chat with one of our pre-service representatives. And then lastly, on slide 31, we basically are trying to stay ahead of Bill 52, and even though there hasn't been finality about should we be posting charges, what does that mean, what definitions, we're going to go based on how we provide our patient statements, which is a combined professional and technical statement, and most likely post the real charges, the allowable, and then the insurance payment, and then the adjustments on the actual out-of-pocket, because patients like seeing that on our patient statements. And that charge is used interchangeably, and it actually, PMMC, Steve on the line, coordinated a meeting for many of us this early evening to discuss the labels, and those labels are being interpreted, et cetera, so that we can all be proactive in their patients' needs in the community before there's a final decision as to what that actually means. And thank everybody for the opportunity. I think the last slide is showing my contact information. I love knowledge sharing and learn what others are doing so I can experience that best practice also. And I'm going to hand it back to Beth. Thank you, everybody, for your support and time in this.
Thank you much, Donna. We'd like to pause and share the results from our final poll. As a reminder, that question was, will your organization be changing price transparency efforts within the next 12 months in response to state legislation? 50% of attendees said yes, 50% of attendees said no, and 35% said they were uncertain. We have for a few quick questions at the end of the conference today. First, we have a question from Angela, who asks, does the estimator directly integrate with Epic?
Donna, not at this time, Angela, it does not. But that's something that we are investigating at this point, primarily in the MyChart section.
Hi, this is Art. I just wanted to add one thing to Donna's comment specific to Metro Health. We have the ability to integrate with Epic. If that's your HIS, we have the ability to integrate from an AD standpoint and other aspects, including the patient accounting system, to send information back, perhaps to an imaging system or whatever you'd like to discuss. Be a good question to speak to your PMMC representative about.
Our next question is from Anne, and she asks, do you standard report you use to validate accuracy, and how often is it run?
We do have an audit report that validates accuracy, and we also always, if the consumer becomes a patient, we literally look at the claim that was produced, and we compare it to the estimate, so that if it's not close to what we had considered, we could reach out to the patient and have a discussion first so there's no surprises.
Thank you. Time for one question left today. If your question was not answered, again, Donna's contact information is there for you. Last question is from Erin, and she asks, is the 0.5% to 1% accuracy rate of the final total charges allowed amount or patient responsibility amount?
That was patient responsibility amount. That's what counts. That's what counts.
So much, Donna, Steve, and Terry. We appreciate all your time today. And thank you all for attending today's Business Partner webinar hosted with PMMC and the Metro Health System, Navigating Price Transparency Requirements, a case study in adapting to state legislation.
Beth, and thank you everybody at PMMC and in the audience. And please, I'm happy to have conference calls with you and your teams and my teams if that's something you would like to do. Thank you.